Welcome to our podcast episode on diagnostic, prognostic, and predictive biomarkers for the treatment of upper GI cancers. I'm your host, Anna Christofides. I am joined by two guests today, including Dr. Christine Brezden-Masley, who is a medical oncologist and the director of the Marvelle Koffler Breast Center at Mount Sinai Hospital. She's also the medical director of Cancer Program for Sinai Health System in Toronto, Canada. We're also joined by Dr. Dr Streutker, who is a professor in the Department of Laboratory Medicine and Pathobiology at the University of Toronto. Hope you enjoy it. So thanks so much, Dr. Brezden and Dr. Streutker, for joining us today to discuss the diagnostic and prognostic markers in the treatment of upper GI cancers. To start, I wanted to ask Dr. Streutker, can you give us a brief history of biomarker testing in upper GI cancers?
Thanks, Anna, for the invitation to talk today. This is a topic that Christine and I have worked a lot on over the years. And this really goes back to around 2010, 2011, when the TOGA trial came out about the results of treating upper GI cancers with trastuzumab and showing that there was actually improved survival in those cases. And that was really the first biomarker for upper GI cancers. Obviously, HER2 testing, which the trastuzumab treatment is based on, has a longer history in breast cancer, but really hadn't been used in anything other than that across the early 2000s. So when the TOGA trial came out, I think there was a lot of excitement on the oncology side, and I'm sure Christine can speak to that. But it ended up being the first one in the upper GI field, and we had to do a lot of adjustments because it wasn't something we were used to doing for those kinds of cancers. And so it was a lot of work to get that set up and running in Ontario.
That's amazing. Yeah, it's nice that you both have that collaboration going on as well. And I was going to ask, Dr. Brezden, what diagnostic, prognostic, and predictive markers do we currently test for routinely as part of clinical practice in Canada? And where in the treatment algorithm do you tend to test for these?
Thank you, Anna, for the invitation. So for upper GI cancers, and we're talking about really gastric and gastroesophageal junction and kind of distal esophagus, but truly for gastric and gastroesophageal tumors, we now routinely we should routinely test for HER2, as Kathy mentioned. There's also mismatch repair proteins that are part of the reflex testing that we should have a report. And we really look at 4 proteins that, if not expressed on immunohistochemistry, that's considered to be a deficiency in mismatch repair protein. And that tumor is considered to be MSI high or microsatellite unstable. So we look at HER2, MMR, and now PD-L1 testing, which now comes to us as either PD-L1 positive or not. And then we look at a combined positive score, or CPS. And depending on the drug that we're looking for, and that's really an immune checkpoint inhibitor, there's a different antibody that is used to determine that CPS score and a different threshold. So if the tumor is HER2 positive and a CPS greater than 1, we can use now trastuzumab and pembrolizumab. This is most recent data, and I'm just really talking in the metastatic setting here. If the tumor is HER2 positive, then we can use trastuzumab. If the tumor is deficient in mismatch repair protein expression, so MSI high, then it is probably the best predictive biomarker for immune checkpoint inhibitors with really outstanding results, both in response and survival. So this is really kind of the predictive biomarkers because they predict the response to treatment. Now, fast forward another 12 months, which both Kathy and I are working on, is the new signal with overexpression of Claudin 18.2. And Claudin 18.2 in itself is a tight junction protein that is actually expressed when a cell becomes malignant. And so now we see that if there's greater than 75% expression of Claudin 18.2 on a gastric cancer cell or a GEJ cancer cell, that now we have another predictive biomarker, and that predicts to the response to a monoclonal antibody known as zolbetuximab. So that is now coming forward, and we're quite excited. That will be part of the treatment algorithm and provide us more treatment options for metastatic patients. The last one I'm going to talk about is NTRK. NTRK is a fusion protein. It really is extremely rare in gastric cancer, like less than 1%. And really the best determination of the presence of an NTRK fusion protein is really through comprehensive genomic profiling, known as next-gen sequencing, or NGS. And that truly is the best way of determining whether or not that is present. And we don't routinely measure or assess for that. So really standard of care that will probably fast forward in the next 12 months will be HER2, MMR, PD-L1 with a CPS score, and of course, Claudin 18.2.
That's great. And do you tend to retest at any point these biomarkers?
So unlike in breast cancer, where we tend to retest on tissue, we don't necessarily retest, but what we do recognize, and there's a lot of data support, is that the HER2 component can be lost after treatment with first-line trastuzumab. And there's data that's about 20 to 30%. And it probably is the fact that we're clearing out the HER2 overexpressing cells with treatment. And we know that gastric cancer is extremely heterogeneous. And because it's heterogeneous, as I said, once you treat, you then can kill off those HER2 expressing cells, and then you have HER2 non-expressing cells. So that's where you could retest. And it's more or less that you could retest for clinical trial just to ensure that the tumor is still HER2 expressing. And we have many HER2 targeted therapies in development and in testing in clinical trials now.
That's great. So, Dr. Streutker, I just wanted to ask how your centers were involved in the biomarkers of HER2, MMR, and PD-L1.
Well, we were, as I mentioned before, involved right off the bat. And because this was such a new thing for doing HER2 in these cancers, there was a lot of caution because it's not the same as doing it for breast cancer. So we had special training in how to interpret it. We had a lot of meetings to say, well, is everybody going to do this, or is it going to be restricted to a few centers? And so when we started off, Cancer Care Ontario was very careful to set it up so that there were a few centers that were very well, everything was validated, all the pathologists were trained, we knew what we were doing, and then we were more or less the trainers and helped other centers get going. So there started up being 6 centers across Ontario, and now I don't even know how many people are doing it, but it's pretty much any center which sees a reasonable number of upper GI cancers has basically set up the testing. So I think most places now that do this can do HER2 and MMR. I think PD-L1 is a bit slower on the uptake, but it's really spreading now. And I think that's largely because when PD-L1 first came out for upper GI cancers, there really wasn't a requirement that you had to have the PD-L1 result. But I think it's increasingly wanted by the oncologist for reasons that, basically you would like to know if the patient's going to respond before you give them a treatment. But also all the new indications that are coming out are really changing how people are using the PD-L1 indication. So we're seeing that demand rise quite frequently.
Yeah, it's amazing how things are evolving. So speaking of that, which treatments actually require biomarker testing and how do they improve treatment outcomes?
So I can speak to that. What we do know with metastatic gastric cancer, GEJ cancer, the median overall survival is approximately 12 months. And so when HER2, when the TOGA trial came out with trastuzumab, that increased to, if you're HER2 3+, it increased it to almost 17 months. So it was a huge improvement in overall survival. So fast forward now, when we take a look at other biomarkers. So for example, when you look at CPS greater than 10 with PD-L1 positivity, is that now we're again increasing survival by 14 to 15 months. Now, that being said, you think, it's only 2 months, but it still is an improvement. It's about a 30% relative risk reduction in dying. And then one thing what we've seen with the immune checkpoint inhibitors is that there is a plateauing. So there is about 15% to 20% sometimes of patients that can be on just immunotherapy and we drop the chemo and do extremely well for a few years. So this is the excitement, is that we don't necessarily know who those patients will be, but usually the higher the CPS score, the better the outcome and response, obviously with immune checkpoint inhibitor. Similarly, with now Claudin 18.2 overexpression, we see about 38 to 40% of gastric cancers that will be overexpressing this protein. And so again, the addition of zolbetuximab improves and decreases the relative risk of dying by, again, 30%. So these continue to have ongoing improvements in survival, response. And the last one I'll talk about that now is moving forward is the trastuzumab, so HER2 overexpression and CPS greater than 1. Again, very robust response rates. These tumors shrink down, and improvement in survival for that enriched population of CPS greater than 1. Lastly, the best biomarker, as I said, is a tumor that is MSI high, or if there's a deficiency in mismatch repair protein. These patients, their treatment is immunotherapy, so an immune checkpoint inhibitor. And these patients, some of them, can be cured with metastatic disease. So it's now remarkable. Unfortunately, only 5% of gastric tumors will have this deficiency in mismatch repair proteins. But the treatment truly is immune checkpoint inhibitors. And we have many of us with patients with tumors that are MSI high are now just, we've treated them, they've had their 2 years of immune checkpoint inhibitor therapy, and now we're just following them. And we sometimes don't know what to do. Do we resect the tumor, the primary tumor, if it's still in situ? Do we just leave them and, continue to monitor them? So this is a whole area now of research, but it's quite remarkable that we can cure the incurable with this subtype of gastric cancer.
Wow, that's amazing.
It's interesting because before we had PD-L1, we were doing MSI testing just to kind of find people who might respond. And then when PD-L1 came out, people did literally say, why are we doing all of these? Because it's an extra 4 slides that we're doing for the immunohistochemistry for the MSI. But Christine has very clearly showed it does make a difference to have both the PD-L1 and the mismatch repair protein immunohistochemistry done.
Oh, that's amazing. And I was going to ask you, Dr. Streutker, can you explain a bit about how PD-L1 is measured and what assays are being used to do that?
It's a bit of a difficult area for pathologists. Basically, what we're looking for is the expression of PD-L1 either on tumor cells or on the closely associated immune cells. So immune cells that are nearby and clearly involved with the tumor itself. But it's not all immune cells. We don't score neutrophils. We actually have to see what's there and figure out which cells to count and which not to count. In the immune cells, we can count any kind of staining. In the tumor cells, we are supposed to only count membrane staining. So it's a complicated system where you have to sort of estimate how many tumor cells are there for the denominator of the equation. And then for the numerator of the equation, we basically have to count how many tumor cells are there and how many positive tumor cells are there and how many positive immune cells. It's not precisely a percentage, but it's more or less out of 100. But technically, if you had a really strong expressing tumor with a lot of immune cells, you could get over 100 for that. But that's basically how it's done. There's some intra-observer variability with respect to how many tumor cells are present in each field and which cells are positive or negative. So we do show each other these cases quite frequently to get a second opinion. And we do have a lot of concern about how the scoring is and whether or not we're doing it effectively. So we try to be careful and have good quality assessment. The issue with the PD-L1 is also the assays are different for the different drugs. We are using the 22C3 as a lab-developed test. And again, the main reason why labs would use a lab-developed test versus the kit is usually a matter of a combination of money because kits are more expensive and depends what machines you have in your lab. Most pathology laboratories have either DACO or Ventana, not very many of them have both. Some places have Leica that's increasingly got a input in the field. So if you don't have the right machine, you can't run the kit as the kit. You have to run it as the lab developed test. So increasingly what people are doing is validating whichever antibody they are using. If they're running it as the lab developed test, you're going to validate it against the kit. But often we are also validating against the other kits. So if we have the 22C3, we're going to validate it against the other kits that are out there and make this particularly the 28.8 assay kit to show that it's a valuable and viable score for both methods of treatment. We don't know in the pathology lab what the oncologists are thinking about in terms of treatment. So all we can do is give our best guess of an effective report. Well, it's not our best guess. I shouldn't say it like that. We do our best to give a CPS score that can be useful, whichever way they're thinking of taking the patient in terms of treatment.
Yeah, I mean, this is really important for us and for other treating oncologists because for first line metastatic gastric cancer, the CPS has to be greater than 5, and we would add nivolumab as our immune checkpoint inhibitor. Now, that's using, of course, the 28.8 assay. And so if it's coming from where Kathy works, so you would then say it's a CPS greater than 5, or do you just say it's CPS greater than 1? Because from my discussions with many other pathologists is that there is a lot of inter-user variability and staining processes. So do you think that CPS greater than 1 technically is probably the best measurement? And do we care if it's 4.5, as we had in one of our tumor board discussions the other day, versus, obviously if it's greater than 10, but anything of greater than 1, as long as it's positive.
Yeah.
Do you think moving forward, obviously a statement should be made for all the oncologists using immune checkpoint inhibitors in this disease?
I do think that they need to have some clarity about, we are pretty sure when it's negative. If it's less than 1, there's very good agreement with less than 1. There's very good agreement with greater than 10, because if everything's staining, then everything's staining. People, you might argue about whether the number is 30 or 35 or 40, but it's well over 10. The real problem is in those cases that are between 1 and 10, where there can be significant variability. I know we're trying to report less than 1, 1 to 5, 5 to 10, and greater than 10 to try to help oncologists get a better idea of where exactly this is. But at the very least, I think it has to be less than 1 or greater than 1. But I think the more specific we can be, I think 4.5 is perhaps, I have gotten away from putting in decimal points, I think, because I don't think it's relevant. But I do think there's a temptation. We keep trying to be very accurate, but I'm not sure it's helpful. But it's just one of those areas where maybe digital pathology will solve this all for us. I don't know. But we need to be very clear with what we're putting down and how it's being used. And with new drugs coming out or new drug combinations coming out and new trials and indications, if somebody else comes along and says, well, our trial indication was a CPS of 5, then we're going to have to go back and redo all these for these patients. So it's difficult. If it would be nicer just to put less than 1 and greater than 1, that would be reliable, but I think it would cause problems down the line.
And noting that gastric tumors are extremely heterogeneous.
Yeah.
That obviously where you stain and where you look, and it's great we have our multidisciplinary cancer conferences, our tumor boards, is that when we actually see the slides from pathology, it's like, wow, this part's staining, this part is not staining. So then what does that mean? We always say if there's HER2 overexpression, regardless where it is, we're going to treat with a HER2 anti-HER2 targeted therapy. So I think this, Kathy, is always our conundrum is if there is CPS greater than 1 or greater than 5, that, this is an opportunity for immune checkpoint inhibition.
Yeah, that sounds very complicated, and with these novel treatments and biomarkers coming our way, what do you see as the most important emerging ones and how they could affect all of this?
Well, as Christine said, the Claudin 18.2 got a very good chance of being active, I guess, within the next year or so. So we've been talking extensively about getting that one set up. which thankfully from the pathology point of view seems like a fairly straightforward assay. What I think is most interesting about that one is that there's a good chance that it will work for the diffuse type of gastric cancer, probably because, as Christine said, this is usually a protein that's trapped into the cell-to-cell linkages where it's not really accessible to any kind of molecules you're putting into the human body. But as the tumor cells lose cohesion as they become malignant, it becomes exposed. And diffuse gastric cancer, we recognize it partly because one of the other terms for it is poorly cohesive cancer. It just kind of all falls apart. So all those proteins that should be holding the cells together, because GI epithelial cells really like to hold together very, very strongly, those tumors seem to have a significant expression of the claudin 18.2. So we might actually be getting a useful treatment, particularly in that subgroup. And that subgroup is one which is very rarely positive for HER2 in particular. And I think it doesn't seem to have a whole lot of PD-L1 expression as well in general. So I think it's going to be a nice option for people for treatment when that one gets going.
Yeah, no, I agree. And that actually is the, when we talked about prognostic subtypes, diffuse, of course, has the worst prognosis. But the other ones that are coming down the pipeline, so obviously then combination therapy. So the Illustro clinical trial, it's a phase 2 that's now looking at zolbetuximab plus nivolumab. So it's now doing dual antibody therapy to see whether or not there's an improvement, obviously, in response rate and survival outcomes. We certainly saw that with the trial called Keynote 811 that combined trastuzumab and pembrolizumab, so an anti-HER2 and an immune checkpoint inhibitor, which certainly showed better survival outcomes in the enriched population of CPS greater than 1. And the reason it's important to do that CPS score is because data from that clinical trial, where there was a CPS less than 1 or 0, there was worse outcomes if you had the dual treatment of pembrolizumab and trastuzumab. So that's why we do have to ensure that we have the proper biomarkers to really guide therapy. When we look at what's in the future, well, the FGFR2 beta is another transmembrane protein that is overexpressed. Now, this number keeps on moving, but it's probably about 15 to 20%. And there is a monoclonal antibody known as bemarituzumab that is extremely effective in combination with chemotherapy. So it's exciting to see that data that will be coming out. So clinical trials are currently open to assess that. So as you can see, we're not going to have a roadmap on, depending on the biomarker, we will be really selecting the best therapy for that patient, kind of like lung cancer today.
I think it's really an exciting time. Obviously not for the patients, but there's more options now compared to in 2010. There was just chemo, which has its uses, but there was very little targeted stuff there. And then HER2 came, and it was a major game changer. But then everything was static for years, and really it took more or less 10 years for another thing to come along, which was PD-L1 and checkpoint inhibitor therapy. And now there's so much activity in this area. There's going to be so many options. I think it will be very confusing for the oncologists to sort out what is the best pathway for their patients. And I think that will take a while longer to settle down as more trials come through.
Yes, no, I agree. And also like sequencing, right? So HER2 enriched, as I said, is trastuzumab and pembrolizumab in the CPS greater than 1, or just trastuzumab if CPS 0. Now we have second and third line options, right? There's trastuzumab deruxtecan, which has shown really great response. So, when you look at overall survival, that continues as we layer on therapy and sequence therapy, those patients will be living longer, which is wonderful. But this is a big area of research, because if that tumor is, HER2 enriched, CPS or PD-L1 enriched, and say claudin 18.2 enriched, which one do you pick?
Yeah.
And then can you not sequence? So I think, as I said, if you're going to treat with trastuzumab and pembrolizumab, second line, if you retest, like you said, now that we have actually treatment options, or will we rebiopsy? Will we retest? is that Claudin 18.2 signal still there? Well, then why can't we use a targeted therapy for that in second line? We don't really have any clinical trials to tell us that. So I think in the absence of clinical trials, in terms of sequencing, we certainly know that if that biomarker is present, to be honest, regardless of sequencing, but if that biomarker is present, can we not target it with treatment? So I think this is where in the future we may get into trouble just based on how these clinical trials have been developed. We really push forward for first line, the very first treatment, because that's when we can really get in the longest and really we want the best treatment. So who knows, if we have 3 biomarkers, should we attempt all 3, provided it's not too toxic? Mm. So these are some of these, interesting dilemmas that we may be faced and challenged with in the future.
Yeah, I was thinking the same thing, Christine, that this may well end up driving the need for repeat testing on either recurrent or metastatic tumors, just to see which, as you mentioned, which clone has escaped and is causing trouble. And it may not be the one that the same sort of cells that we tested in the reflex testing in the first place.
So thinking about all of that, and I know it's hard to make a roadmap, like you said, Dr. Brezden, but if you were to try to think of what testing algorithm you would use, say now or in the near future, what would it be the ideal thing?
So based on all the trial evidence and the data that we have, and being a predictive marker predicts for response to therapy, it is at the time of biopsy, and Kathy and I have discussed this multiple times, at the time of biopsy to ensure that we have 4 slides stained for HER2, MMR, PD-L1 to get a CPS score, and then it will be Claudin 18.2. And that, I think, in the next year is really what should be the standard of care. And as the data reads out for FGFR2 beta, that will probably be the 5th predictive biomarker that will need to be tested at the time of diagnosis. So this is reflex testing.
And speaking of reflex testing, Dr. Streutker, how could that be implemented into Canadian labs?
In Ontario, it's predominantly happening as reflex testing. I think this, again, was a concept that we really had to push for people doing gastrointestinal pathology because it wasn't something anybody was used to, honestly. Again, in breast, as soon as you get breast core biopsies showing cancer, you're doing HER2, ER, PR, it's truly reflex. But it was a new thing more than 10 years ago when we had to get this set up. And I think in Ontario, the majority of cases do get reflex testing for HER2, MMR, and PD-L1 now. Again, PD-L1 is perhaps a little bit lagging, but I would say probably the majority of cases it's getting done. We still do see some cases come through where there weren't biopsies, either there weren't biopsies before or the biopsies didn't get sent for testing, and we end up getting resection specimen for testing. Again, the other problem that we're trying to work on now is making sure that the reports are out there for people to find. So we're never quite sure if the testing happens somewhere else because people are biopsied in one center and then sent off to someone else. And then if they have surgery, it's quite another place. And the Ontario system, at least, is not always easy for the oncologist to find what results are where. So that's something we need to optimize. But reflex testing across Canada is patchy because predominantly of money issues, honestly. We are very fortunate in Ontario that Cancer Care Ontario has made a major effort to increase the biomarker testing. It took a long time to get some of these funded. We argued for 10 years to get MMR funded by Cancer Care Ontario. But HER2 actually happened fairly quickly, and the changes over the last couple of years have been much more nimble and much more taking into account the rapid changes going on in the field. So I consider that we are very fortunate in Cancer Care Ontario, and in particular, Aaron Pollitt, who is guiding a lot of this. And he's one of the pathologists who's the head there at in Cancer Care Ontario on the pathology side, who has really driven this. Outside of Ontario, BC, everything is centralized, which makes it easy for them to manage setting up new tests. But across Canada, not all the provinces have it as organized as we do here. If they don't fund it, then pathology labs are constantly underfunded. And so therefore, they would be waiting for an oncologist to ask for it before they'll do it, because they're not going to spend the extra money unless they have to. And that causes significant delays for the pathologist to get the case, to do the stains, and get the report out, so that the patient may be waiting for weeks to get their results, which in people who do not have, in a lot of cases, a long survival time is very hard on them. And I think reflex testing, again, it's all about money. And so if you want true reflex testing, the provincial governments have to be much more nimble in accepting the cost and organizing this for the pathology labs.
Yes, I do want to put that plug in, because metastatic gastric cancer patients are very unwell. And you can imagine, their nutrition is poor. We really need to start the best systemic therapy and targeted therapy. And so as an oncologist, if I have to wait 3-4 weeks to get that, I mean, we can always start chemotherapy, but again, it's always nice to start the best treatment up front and to support our patients. So this is very patient-centric, patient-driven, that we really want to have that information at the time we are seeing that patient.
So speaking of these different barriers, what other challenges exist, like considering all of these new biomarkers and the need for new assays and so on? What do you see as the other challenges that exist for the future treatment?
I think on the pathology lab side, obviously getting the test funded once it is approved by Health Canada is important, but it's also very expensive for us to just get a test in-house and validate it. There are very, very strict requirements about how to implement biomarkers to ensure that we do a good job, to make sure that the results are reliable and can be trusted. This is expensive. And it's hard enough for cases where the incidence of, you need to test a certain number of positive and negative tests to make sure that things work. That's not so bad for things like for Claudin, it's 30 or 40% of cases are positive. For gastric cancer, HER2 is positive and in the ballpark of 20% of cases. So that might mean if you need to do 20 positive cases, you're going to test probably in the ballpark of 100 cases. And there you've got your 20 cases. Hopefully, I mean, statistics is always going to mess with you on that, but you should be okay and be done. And each slide costs between $20 and $50 to do the whole immunohistochemistry thing. You have to find the cases and pull them out of storage. So it's thousands and thousands of dollars just to get validation done for a marker that has reasonably high expression in the tumors. If you're looking at NTRK, which, as Christine said, is excruciatingly rare, how do you get those 20 cases together? You'd have to test 20,000 odd cases. So it is extremely difficult to validate tests like that. So yeah, it's, again, sadly, it comes down to money, to some extent time. We're suffering from massive human resource issues in pathology labs across Canada. It is another impact on us just to get the test set up and to do the readout, which for some of them is very quick, but for things like PDL1, it is a significant chunk of time. And the funding from Cancer Care Ontario only covers the technical side, not the impact on the pathologist who has to read it.
So on the medical oncology side, it takes a very long time once the clinical trial data reads out and is published for us to actually have access to the very effective medication for our patients. And if it's tied in to a biomarker, that then does create challenges, because as Kathy stated, it takes a long time to validate and do that testing. So if there's a companion diagnostic that is associated with our treatment, it can be delayed again, because we won't know if that biomarker is present if we haven't taken all these steps to ensure that we have it validated and available by our pathologists. And something Kathy said earlier, and this really needs to be discussed because it's extremely important, is that there is patchy reporting for us. So if you're at a center where you only have HER2 testing and maybe MMR, it then will have to go to another institution where there is PD-L1 CPS testing and now say Claudin 18.2. And it's sometimes like an extreme challenge to actually then hunt for those tests as they were been reported, because sometimes it doesn't come into a comprehensive, I would say, synoptic report that all of your biomarkers are put in one report, as opposed to, it's at a different hospital here, at hospital B over there, and then you have to start looking for it. So that creates a huge issue for us.
Well, yeah, that's a lot to digest, I'm sure. Just thinking also, we talked about the reflex testing, but I wondered when would be the ideal time to retest, and which biomarkers would you want to retest for?
So, as tumors progress on treatment, so say your patient has HER2 CPS greater than 1, and you're treating with trastuzumab, pembrolizumab chemotherapy, and then the tumors after a year or a year and a half, you're lucky 2 years, they start progressing. You can take another biopsy and test to ensure that there's HER2 overexpression still, so that you can have access to, say, trastuzumab deruxtecan. Right now, we don't need to retest because we don't have any predictive biomarkers for second line or third line. In second line, even if the tumor was HER2 overexpressing, we would treat with paclitaxel ramucirumab as per the Rainbow clinical trial. And so there were HER2 overexpressing tumors in that clinical study. But as we're seeing now, second line, third line, as this emerges over time, we may need to have to test. But today, we don't necessarily need to test, except to perhaps demonstrate HER2 overexpression is still present with trastuzumab deruxtecan.
Makes sense. So I just wanted to end with some discussion around any kind of research or clinical trials that you're both involved with, and how you see the results of these studies perhaps influencing clinical practice.
Well, we had the Spotlight clinical trial open, which was the Claudin 18.2 overexpressing with chemotherapy. It was backbone FOLFOX chemotherapy plus or minus zolbetuximab. And, clinical trials in advanced gastric cancer, as I said, many of these patients are unwell. And so one thing, if we can offer patients clinical trials, i.e. research studies, I always say that these are the Olympians of, gastric cancer, because they have to be well enough to wait to get all of the necessary testing done before we put them on study, before we randomize them and consent them to study. They have to be well enough. And then we have to wait for that predictive biomarker before we can randomize them. Some clinical trials are allowing us to have a run-in of chemotherapy before we randomize them, which I think is extremely important for this population of patients, because, as I said, gastric cancer patients are truly unwell, and many of them cannot go on study because of the fact that they don't have a great performance status. So that is our challenge. But again, we continue to study and make sure that we improve, find new predictive biomarkers, drug discovery, and continue to improve outcomes. I mean, the excitement is there is, CAR T therapy, or, looking at targeted antiviral therapy, targeting HER2, targeting Claudin 18.2. So this is where now it's coming extremely exciting times, is that the novel therapeutics or antibody drug conjugates, right? Novel therapeutics where we can really target and deliver precisive, high dose chemo or precisive improvements in immunotherapy to these tumors to really eradicate biomarker driven tumors. So it's exciting. And I think in the next 5 to 10 years, this landscape will be very different than it is today.
Yeah, that's amazing, the progress that has been made. Dr. Streutker, do you also have any final thoughts you'd like to share?
We covered a lot of ground here today, but I think Christine is right that there's so much interest in this area that I think what we're talking about now is probably going to be outdated in a year or two because there'll be all kinds of new things coming on. I do think that people are starting to look at, there were so many trials that were done in the past where they tried targeted therapies and things failed. And I think people may well be looking back at some of those and saying, well, did we actually sort the patients well enough? Did we actually do the right biomarker to say which patient might actually benefit from this or not? So I think there's so much interest. There's so much going on and so many trials. Again, I think we're really making changes here for people that will improve their life and hopefully extend their life.
Well, I wanted to thank you both for such an interesting discussion, and I'd love to talk to you both again, maybe in a year to see where we're at then, because it seems like so much progress has been made. So thank you both for your time on this.
Thank you.
Thank you again.